The so-called niacin flush has long been regarded as an inconvenient or even problematic side effect, often cited as the primary reason individuals discontinue niacin therapy. Yet this reaction, characterized by warmth, redness, and tingling in the skin, deserves a more nuanced interpretation. Rather than being a sign of toxicity or harm, the niacin flush reflects a predictable physiological response, vasodilation mediated by prostaglandin D2 and E2 release via activation of the GPR109A receptor. In this context, the flush may not be a mere nuisance, but a visible, tangible biomarker of pharmacological engagement, an indicator that niacin is not only circulating but actively interacting with receptor systems involved in lipid metabolism, vascular tone, and inflammation resolution. When viewed through this lens, the flush becomes less of a side effect and more of a signal, a marker of therapeutic action that NR and NMN notably do not provide. The mechanism behind the flush is well characterized. When niacin binds to the GPR109A receptor, also known as hydroxycarboxylic acid receptor 2, or HCA2, it stimulates skin-resident immune cells, such as Langerhans cells, to release prostaglandins. These prostaglandins cause vasodilation of dermal blood vessels, leading to increased blood flow and the characteristic flushing effect. This cascade is transient and typically subsides within 30 to 60 minutes, particularly after repeated use, as tolerance develops. Importantly, this is not a histamine-driven allergic response, but a controlled and reversible vascular effect, one that overlaps mechanistically with niacin's other benefits. GPR109A is expressed in adipose tissue, immune cells, and vascular endothelial cells, suggesting a much broader therapeutic relevance than skin flushing alone. Its activation reduces lipolysis in adipocytes, lowering circulating free fatty acids and improving lipid profiles. In macrophages and monocytes, GPR109A signaling downregulates inflammatory cytokine production and promotes the anti-inflammatory phenotype, a critical function in the context of atherosclerosis and metabolic disease. This anti-inflammatory action is not just theoretical, it is part of the mechanism through which niacin exerts cardioprotective effects beyond lipid modification, as evidenced by its ability to raise HDL cholesterol and reduce small, dense LDL particles in clinical trials. By contrast, NR and NMN, despite their efficacy in raising intracellular NAD, do not activate GPR109A and thus do not produce a flush. This absence is often marketed as an advantage, allowing users to take higher doses without discomfort. However, this comfort may come at a cost. Without GPR109A activation, NR and NMN fail to engage prostaglandin-mediated vasodilation or exert direct receptor-mediated effects on immune modulation and lipid metabolism. While they influence sirtuin activity and mitochondrial function indirectly via NAD elevation, they bypass the receptor-mediated arm of niacin's pharmacology entirely. In a therapeutic landscape where systemic inflammation, endothelial dysfunction, and lipid abnormalities are tightly interwoven, this omission may represent a limitation rather than an advantage. Furthermore, the flush provides users and clinicians with a clear, real-time indication of bioactivity, something NR and NMN lack. Because their cellular uptake is more complex, often dependent on transporter expression and extracellular metabolism, it can be difficult to verify in practice whether these compounds are effectively reaching their target tissues. The niacin flush, on the other hand, confirms that the compound is active in the body and triggering known biological pathways. That said, the discomfort associated with the flush is real for many users, and strategies have been developed to mitigate it. Extended-release niacin formulations and co-administration with aspirin have been shown to reduce prostaglandin-mediated vasodilation without compromising the lipid-lowering effects. Moreover, consistent dosing over time leads to rapid development of tolerance, often eliminating the flush entirely within a few days to weeks. Importantly, no evidence links the flush to long-term harm. In fact, studies have shown that even high doses of niacin, up to 3 grams per day, are well tolerated when properly managed, with liver monitoring in place. In conclusion, reframing the niacin flush as a therapeutic biomarker rather than a side effect opens the door to a broader understanding of niacin's systemic benefits. Rather than being dismissed or avoided, the flush can be interpreted as evidence of vascular and immune engagement, a kind of built-in signal that niacin is doing its job. While NR and NMN avoid this visible effect, their lack of GPR109A activation may represent a blind spot in their therapeutic profile, especially in conditions where inflammation, lipid dysregulation, and endothelial function are central. In the balance between bioactivity and comfort, the flush may be an acceptable, even desirable, feature, especially for those seeking holistic, system-wide metabolic enhancement.